I'm really delighted to be here in Denmark. And as Søren says, I come from Wales, and we're really famed, not me personally, but the country is very famous for its music and singing. So I kind of feel this is a real letdown that I'm going to have to talk to you about science after the wonderful music we heard earlier. But here I am. I'm going to talk about genetics, but I'm going to take a very clinical perspective and how has it helped, if at all, our conceptualization of psychopathology. These are my disclosures. The income I get is from Cardiff University. So, in terms of my overview, I'm going to, first of all, just refresh our memories. We're all familiar with it. What are our current concepts, the ones we use in clinical practice and research, and what are the challenges we face daily with the concepts we use? Then I'm going to consider the genetics research, and actually how well do our current concepts map on to the biologies that are emerging from such genetic research. How good, as the genetics has shown us, that we are at demarcating atypical, what we call disorder, from typical, the typical spectrum of development and mental health. And I think one thing that we all have in common in this room is that we are trained very strongly in a developmental perspective. So how well do our current concepts actually capture developmental change and heterogeneity as a whole? And finally, I'm going to end with some future research and what's dearest to my heart, what potential clinical implications are there from the research. So let me begin with our current diagnostic categories. DSM-5, ICD-11, we're all familiar with those two classification systems. So why do we need these systems? Whether we love them or hate them, they do enable us to communicate. So if I am discussing a patient who's got depression or ADHD, and I talk to Anne-Marie or Søren or any one of you, you will have an idea about what sort of issues I'm talking about. So we need them to communicate. Many of our clinical decisions are really very categorical. So we see someone in clinic and we need to make a categorical decision. For example, do I make that decision to treat with medication or not? And particularly in child and adolescent psychiatry, we want to be careful with that decision. So we need categories for those yes-no decisions. So I don't quite know what's happening here, so maybe our technical person can help here. Also, if I'm in clinic and I'm seeing somebody with depression, seeing somebody with ADHD, how do I know what treatment to use? I'm not going to use an antidepressant first line for somebody with ADHD. I want to apply evidence from research which includes people with a similar sort of category to the condition I'm seeing in clinic. Also, for patients and families, they also want to have some understanding so they can access support, talk to other families with similar problems. And for those of us who are researchers, it means that wherever we are doing our research, in whichever bit of the country, which country, we're defining a broadly similar set of problems when we are using diagnostic criteria. However, I don't think I need to say this to this audience, but just of course, we have so many different challenges with our current diagnostic categories, which we experience day to day in clinical and research. First of all, so many of the problems we see lie on a continuum. So, for example, if we take the example of depression. So, on the one hand, we have low mood, coping, but coping. Yeah, this is normative. We are not going to get involved as psychiatrists typically. You then start having low mood, which is more prolonged with other sorts of symptoms. And finally, the full cluster of what you might call a DSM or ICD, major depressive disorder, with risks increasing gradually across that spectrum. So it's often not clear where our diagnostic boundaries lie. The other challenge we have, and I think particularly if you're medically trained, certainly when I was at medical school, we were trained the rule of parsimony, make one diagnosis. But of course, we rarely see individuals with one type of problem. Either there's full-blown comorbidity, they have multiple disorders, or they have one primary disorder and they have features of another disorder or multiple other disorders. So again, that is a challenge with the current system we use. The other issue we have is thinking about development. We may see children at different ages, and of course they change across development. So, for example, if we take the example of a psychiatric disorder, they may present in early life with all the vulnerabilities and the antecedents. We may or may not see them then. They then can present with a frank onset of psychiatric disorder, which may, we hope, result in full recovery, but others, unfortunately, will show recurrence or persistence into adult life. So if we take the example of schizophrenia, we know that individuals who develop schizophrenia at higher risk, they may show social, language, and motor difficulties at the start of their life in early childhood. They may then present in adolescence, perhaps the first time we see them, with a first episode of psychosis. They may then, in adult life, it becomes more clear-cut that they've developed chronic schizophrenia with recurrent episodes. The other challenges we face are diagnostic transitions. And I always like to think of the example where I've seen someone in clinic, or one of my colleagues has, and my adult psychiatry colleague has picked up the case several years later and say, "Ha, you missed this." Yeah? And you say, well, no, sorry, I didn't miss it. Come and see my clinical history. They did not present at that time with those sorts of features. Because, of course, we have diagnostic transitions. So if we take the example of ADHD, we may see a whole constellation of other problems. And, we recognize that many of those children may continue to have adult ADHD, and we have the issue of then transitioning into adult services and helping with that transition. However, your adult colleague may come and say, well, actually, they've got major depressive disorder, or, as I will often see in clinic, they develop it when they're in adolescence, still under CAMS. They may present in forensic services, or especially if they've been missed in prisons or in substance misuse services because of transitions here, self-harm, suicide, bipolar disorder, and even psychosis. So we also have the challenge of diagnostic transition. The other challenge we face with our current conceptualization is huge heterogeneity, and every one of you who is a clinician knows that we may call something a single diagnosis, but it's a bit like calling a bowl of fruit. It's one thing, but within that there are so many different types. And we might see somebody in a typical ADHD clinic or a CAMS clinic, people with the same diagnosis who are so dissimilar to each other for a whole variety of reasons. These are some of them. They may, actually with the same diagnosis, have completely different symptom profiles. So someone could have low mood and a lot of the cognitive features of depression. Someone might have very marked anhedonia, sleeping, eating, vegetative difficulties, entirely with the same diagnostic category. Of course, the same diagnosis may present at different ages, childhood, adolescence, adult life. They may also have different outcomes, as I've highlighted before. There may be spontaneous recovery, or the outcomes are really different in the longer term. Again, huge heterogeneity. They may all start off looking the same. The most frustrating thing for those of you as clinicians, and certainly one of the things I find most frustrating, particularly because we're dealing with a young age group and time is so precious, trial and error to find out what's going to work for each person. We heard in one of the medication sessions I was in this morning, we're going to do another one tomorrow morning at 9:30, is that you have one person and it's a trial and error until you get the right treatment, and particularly with medication, that can take a long time. So I've highlighted the challenges with our current diagnostic concepts. What about the research? Let me just turn to the genetics. How well do the concepts we recognize clinical difficulties, actually map on to biology? So we've known for some time, using traditional family and twin designs, that Most of the psychopathologies we see tend to breed true, not inevitably, but if we see somebody with depression, there's a higher risk of depression in the next generation. However, what family and twin studies have shown very clearly is that these familial and genetic risks don't respect our diagnostic criteria. They will cross diagnostic boundaries. So, the parent with one disorder may have children with multiple different disorders. So this is an example. This is a study carried out in the United States looking at high-risk offspring where the parent had bipolar disorder. As we might expect, an increased rate of bipolar disorder in the offspring, but also other conditions, disruptive behavior disorders, ADHD, depression, and anxiety. So we do not have family and twin studies suggesting diagnostic boundaries are really rigid. What about molecular genetic signatures? Well, there are two types of genetic studies. This isn't a lecture about what genetics is, but it's really quite easy that the types that we're trying to find variations associated with a higher risk of psychopathology. And the types of variation that we look at can be either common, they exist in more than 5% of the population, or rare. And that's as much as you need to know. So, common gene variants. So, as I've said, they're common. Yeah, 5% of the population will carry them. And these sort of little variations that we're looking at are called single nucleotide polymorphisms, SNPs, and we're looking for the small percentage of the genome where we're different, every individual, and looking at people with a condition versus basis case control studies. These are known as genome-wide association studies. Because we test millions of genetic markers, these single nucleotide variations, you can imagine if you're doing 1 million statistical tests, to get genome-wide significance, p times 10 to the minus 8, for all that multiple testing, you require tens of thousands of cases. That has been quite quickly assembled for a lot of physical health conditions, but has been, of course, more difficult in psychiatry. Nevertheless, through collaboration, including, the star of the show, of course, is Denmark with ESCAP, but there have been over 100 gene variants, common gene variants discovered for schizophrenia and depression, between 20 and 100 for bipolar disorder and ADHD, and around 5 at the moment for ASD. And other disorders are also being looked at, eating disorders, PTSD, but they do require large sample sizes. So these are the individual common gene variants. Okay, what do they show? These genome-wide association studies. Well, yes, of course, ADHD, common genes in one study predict those in another study, but we've got extensive genetic correlations between different psychiatric disorders, some more prominent than others. I always remember the ADHD depression one is very prominent, and I'm going to mention some of the others, these common gene variants also don't respect our diagnostic boundaries. I also told you about the other type of gene variant that we look at, which is rare, which is less than 1%. And because the ones we pick up, because they're rare, tend to have large effect size, so sort of odds ratios between about 2 to 40, really quite large effect size, those are the ones that my neuroscience colleagues are most interested in getting insights into biology. So I think everyone is familiar. For a long time, we've known rare Mendelian disorders like tuberous sclerosis can present with psychopathology and neurodevelopmental disorders like ASD. But in the last decade or so, 20 years, 10 years, people have also been looking at more subtle, rare gene variations, stretches of DNA that are duplicated or missing, deletions, chromosomal deletions and duplications. These are known as copy number variants. People with neurodevelopmental disorders and schizophrenia seem to have a higher burden compared to controls. Also, people have looked at single variants which are potentially damaging. They result in protein alterations. And again, people at the moment, because you need such large sample sizes and it's so many markers you could look at, they're focusing on the coding parts of the genome. And again, have been found, a number have been found for neurodevelopmental disorders. So these rare genetic variants, the copy number variants and sequence variants, also seem to cross diagnostic boundaries. Unsurprisingly, the majority of discoveries have been found for intellectual disability, but more than 100 for autism spectrum disorder, and they also overlap with ones discovered in schizophrenia, also overlap with ADHD and Tourette's. So again, not respecting our diagnostic boundaries. So, summary, do our current diagnoses have distinct genetic and biological signatures? Well, no, they're not clear-cut. So, am I telling you, oh, we can forget all about diagnoses? No, because of course, as I've pointed out, they're a concept, they're not set in stone or biology, but we still need them to communicate, do research, get evidence-based information. And whilst every geneticist will say, yes, of course, there's just pleiotropy, there's so many shared genetic risks across psychiatric disorders, I tell people, well, we can't abandon our categories just yet because the treatments aren't identical. Whilst there's wide overlap, we're not going to use first-line stimulant medication for treatment of psychosis, for example. So we can't dispense with diagnostic categories. Also, while I've highlighted that the predominant flavour is overlap, not specificities, there still are some distinctions. So this is the genome-wide association studies, looking at the genetic correlations between different disorders. If someone could just get rid of that marker, please. And basically what this diagram shows is that the early onset neurodevelopmental disorders appear to be clustering together. The mood and psychotic disorders seem to cluster together, and also the disorders with compulsive problems. And rare variants, as I've said, seem to cluster particularly in neurodevelopmental disorders. So I'm looking to our tech to move on.
Could you, technical assistant, thank you.
Thank you. As I've said, copy number variants and rare, likely damaging sequence variants seem to be more enriched in neurodevelopmental disorders and schizophrenia, not so much in prominent, not absent totally in mood disorders, eating disorders, etc. So, I've said that current concepts don't map cleanly onto biological entities. What about demarcating atypical from typical? As I've mentioned, many of the conditions we see do lie along a spectrum, which could be seen in the general population. What does the genetics suggest? I'm going to come to that in a minute. Well, do we view the conditions or, if you like, disorders that we see as traits that exist in the general population, where we just see people to the far right, those who score particularly high, and we call affected? So a bit like blood pressure in the general population, hypertension, cholesterol, and high cholesterol. Do we look at the psychopathology as a trait or category? This is really quite fundamental. So let's take some research on ADHD. Joanna Martin, who works with me, did some of this work very early on, where she took common gene variants and made a composite score, which I'll talk about later, from patients with an ADHD diagnosis, and found that it predicts how many ADHD symptoms people have in the general population. That's been replicated across other samples. And actually at the bottom, you will see that the genetic correlation for common gene variants between ADHD diagnosis and ADHD symptom levels in the general population, so not people with diagnosis, is 0.9, really high, suggesting that ADHD as a diagnosis seems to lie on at the end of a population continuum. What about ASD? Well, this is work from Elise Robinson suggesting something similar, where common gene variants for autism spectrum disorder seem to be associated with social communication traits in the general population. Same for major depressive disorder. We think we might consider this as illness, but when we take the common gene variants associated with illness, they seem to predict number of symptoms in the population for adults and young people. And similar findings have been found for other psychopathologies, for example, Tourette's and tic disorders in the general population. So this is a dilemma for us as clinicians. We have categorical diagnoses, and yet epidemiology, we've known for some time that risk factors, correlates, and adverse outcomes, there isn't really a clear cut point beyond which these start operating. And the genetics shows something similar. Perhaps one exception might be the relationship between schizophrenia, the disorder, and psychotic-like symptoms in the general population, where findings are mixed, because in adult life there does seem to be a genetic correlation, whereas in youth the findings are more uncertain. So, do genetic signatures really cleanly demarcate atypical from typical? That would be so nice. We could all retire and just do genetics in our clinics. I'm afraid not. There are genetic overlaps between diagnoses and population symptoms. So do we switch entirely to dimensional approaches? Well, I just want to point out that disorders are not exactly the same as the population dimensions research has been done on. Because if we take a diagnosis, let's say ASD, we're usually looking at multiple different dimensions. So for example, social communication, repetitive restrictive behaviors. We're looking at multiple different dimensions. We also don't look just at symptoms, we look at functioning. But there is a greater appreciation now in research and for clinical purposes that we need categories and dimensions. We can't just use categories. So, what about developmental change and heterogeneity? Very dear to us as child and adolescent mental health researchers and clinicians. So, we're all familiar that different types of psychopathology, typically, not always, we may see atypical onset at different ages. So the childhood neurodevelopmental disorders like ADHD and ASD, typically, but not always, tend to be first start manifesting from early childhood onwards. They may not get picked up then. Anxiety from childhood onwards, but the different types of anxiety disorders coming on at different ages. So for example, generalized anxiety disorder, agoraphobia coming on sort of later than, say, separation and social phobia, and mood disorders and psychosis, schizophrenia, coming on from adolescence onwards. So how important is it when we see people where age at onset is atypical? And of course, because we see our children and adolescents, any individual we see with schizophrenia, bipolar disorder, or major depressive disorder is early onset. So I always find it interesting that what we call early onset in child and adolescent is really quite different from what an adult psychiatrist would call early onset. Nearly all the genetic studies have shown that those people who have a particularly early onset form that's more strongly familial, so that causes difficulties perhaps for us when we're seeing whole families and we see multiply affected relatives with different types of problems. It's more heritable and greater recurrence and chronicity and worse prognosis when there's an earlier onset. So we actually do get the most sort of challenging, hardest subtypes of these sorts of conditions and often difficult to treat. So, if I move from age of onset, let's think about the same disorder and symptom. Does it actually mean the same at different ages? For most purposes, our diagnostic classifications, whether DSM-5 or ICD-10, 11, sort of presume a similar sort of diagnosis, the criteria could apply at different ages. But does the research evidence suggest that? Well, let's look at depression to begin with. Is it the same disorder at different ages? Well, there's a lot to suggest that it is. So that's fine for classification. Children and adolescents who suffer from a major depressive episode, unfortunately, they are much more likely to show recurrence and show further episodes of major depressive disorder into adult life. So there's strong continuities here. The offspring of parents with depression are also at elevated risk of depression. So again, suggesting it's the same sort of disorder, suggesting it's the same liability operating across ages. So we can relax perhaps. But there are also differences, which I think we have to pay attention to. And sometimes perhaps as scientists we may forget. In childhood, the sex or gender ratio is the same. And it's only from adolescence onwards that female preponderance emerges. We, of course, have moved into an era, usually of people using SSRIs, but in the days when adult psychiatrists would use tricyclic antidepressants, meta-analyses to suggest that they're not as effective as in adulthood. What about genetics? What about the genetic signatures for depression at different ages? What do we know there? Well, the studies of Genetic studies of depression have, of course, been based on those over 18 in adulthood. So when they look at early onset, they're generally looking at people before the age of 30 or 25, not what we would call early onset. But what those studies suggest is that the earlier age onset of depression seems to have a different genetic profile. It's still associated with depression genetic risk scores, a composite of common gene variants, but is also associated with schizophrenia and bipolar genetic risk scores. These were adults. Let me turn to some youth depression research. So this is some work we conducted. Francis Rice was the lead here in ALSBAC, which is a UK population cohort who's been followed up from birth until they're now in their early 30s, actually. So we looked at depression symptoms from age 10 and across adolescence. This is a health general population. So you can see the bottom line, most of the population have low levels of depression symptoms. The middle line, the orange, is what you would say your sort of typical mid-adolescence onward. The rates start increasing, more females in that group. And the blue is they start much earlier and what we called persistence, that they seem to, we followed them up to 25, they seem to have a worse clinical course. We found different genetic signatures. Both were associated with depression, polygenic risk scores, genetic risk scores, but the early onset was schizophrenia and ADHD genetic risk scores, suggesting different genetic signatures at different ages. So, depression across childhood and adolescence. On the one hand, there's research suggesting across the lifespan there may be a lot of similarities, but the profile is different patterns of association with sex, genetic risk profiles. So I think, of course, at the moment we're stuck with the concepts we have, but we do need further developmentally informed research on depression. What about the same symptom at different ages? I'm going to take the example of irritability now, which of course is transdiagnostic. I think everyone here knows what we mean by irritability, increased proneness to anger, and it's a really common reason for referral regardless of diagnosis, because of course it's disruptive for the child, family, and schools. In ICD-11, it's a specifier of oppositional defiant disorder, but the APA motivation was somewhat different because of practice in the US, and it's considered under the mood disorders severe chronic irritability because of longitudinal and genetic links with depression, which made it look quite distinct from bipolar disorder. So irritability. Irritability seems a really straightforward, okay, it's transdiagnostic, but symptom, if you like. Again, this is work conducted in ALSBAC, the UK population cohort by Lucy Riglin and Olga Eyre. So this is looking from childhood to adolescence and irritability symptoms in the general population. Most will have low symptom levels, as you would expect. Some are really high right from the start, and I'll focus on those, the high persistent, and some start increasing in adolescence. And what they found is that those with chronically high irritability from childhood onwards were more males than females and associated with ADHD genetic profiles, whereas the later increasing irritability was more females and associated with depression genetic risk profiles. So, the meaning of irritability, it's a transdiagnostic concept, it's in different diagnostic classifications, but what we're seeing is different patterns of associations and with sex and genetic profiles, so suggesting we need to be a bit cautious that the meaning of irritability might depend in part on age, something which is very familiar to us who have been trained in a developmental perspective. So moving on from development to heterogeneity, as I've already mentioned, we have huge heterogeneity, and this is even without considering heterogeneity in the individual strengths and social context. But thinking about clinical heterogeneity. So let me take, first of all, heterogeneity in symptom profiles. So I'm going to take the example of psychosis. So psychosis, can present in people with schizophrenia, also with bipolar disorder. And there's a huge symptom overlap between schizophrenia and bipolar disorder, and actually the genetic correlations between these disorders is also very high. If we could please remove that. I seem to be needing IT here.
Technical assistance, please, again. Thank you.
So, psychosis symptoms, regardless of diagnosis, increased schizophrenia polygenic scores appeared to be associated with psychosis symptoms in those with bipolar disorder. So actually the genetic risk scores seem to be more mapping to the symptom profile than the diagnosis in this instance. And the increased bipolar polygenic risk scores in those with manic symptoms in schizophrenia was associated more with the manic symptoms, the bipolar polygenic scores, suggesting that symptom profiles, the heterogeneity is also mapping on perhaps to different genetic profiles. What about different ages at onset? I've said there is maybe some difference in genetic profiles for depression. And in the future, one thing I think people are really curious about is whether the rare large effect size gene variants that I've talked about are more prominent in those in the conditions we see. That's a research question that has to be answered. What about chronicity versus remission? I think it's a common question in clinical practice. How many of you in clinic get asked, what is going to happen to my child when they grow up? And, we have to give some sort of information based on what the clinical diagnosis, but also family history, social, and it's the question, and you want to be optimistic, but the actual reality is we don't know. That people may look the same, but turn out quite different as they get older. So, can we dissect heterogeneity here? I'm going to take the example of ADHD. Some people will remit, but of course a very big percentage will carry on having ADHD until adult life. Those with persistent ADHD seem to have a higher familial loading. So what we found, again, this is work conducted in the Alsbach cohort study, is that there was a group, and if you see, that remitted. These are the group in orange that we call childhood limited. They had at the beginning, at age 7, they looked just the same as those who remitted, as those who carried on having ADHD till late adulthood, but they had higher ADHD genetic loading in terms of polygenic risk score, but not for other psychiatric disorders. Treatment, the ultimate question we want answers to. What are people going to respond to? Can we do that at the outset? This is lovely work carried out in the Danish registry by Søren, Isabel and colleagues, where they looked at your wonderful Danish registry data and looked at people with ADHD who discontinued stimulants and switched to non-stimulant, which can take us months before we get to that point where we realize this is going to happen. Could they distinguish them? Well, they found that those who switched or discontinued had more of a likelihood of delayed diagnosis and comorbidities, but also slightly different genetic signatures, increased schizophrenia and bipolar genetic risk scores. Treatment resistance in depression. I'm also going to talk a little bit about that. So many of our adult colleagues, I don't know how many adult psychiatrists are here, but we have people who just do not respond to antidepressants, and you may see that in the parents of some of the children we see. Could they distinguish those with treatment resistance, major depressive episode, from those without? And what people found is that actually ADHD polygenic risk scores, neuroticism is very closely correlated with depression, scores were associated with treatment resistance. Not a huge effect size. You can see, very small, as is often the case with common gene variants, but associated with ADHD genetic risk scores. Of course, I asked my statistical genetics colleague in KCL, I said, well, how many of those people with treatment-resistant depression actually had ADHD that was missed? Because we have also shown that in another study of people with chronic depression having undiagnosed ADHD, and they don't know, but this is what they found. So, conclusions from the genetics. Our current diagnostic concepts don't map cleanly onto biology or emerge as distinct categories, I'm sorry to say. They do not really make it very easy for us to distinguish typical from atypical. So psychiatrists, psychologists still have a job. They just can't do it. Developmental factors matter, age of onset, and the biological underpinnings of disorder and symptoms may be different at different ages, and that's a huge problem for us if we're relying on treatment studies or RCTs from adult life and then taking them downwards. And heterogeneity, I've given you a bit of a flavour, but it's too early. We just don't have enough research here to dissect that. So I'm going to end with future research and clinical implications. I've talked a lot about these composite genetic risk scores. You probably have seen them, polygenic risk scores. It's not really rocket science. You have a genome-wide association study of, say, cases, let's just say ADHD and not ADHD controls. You take those that are enriched in the cases, the common alleles, multiply them by the effect size in a second population that's got to be different, and you sum it up for each person, all those risk alleles. And that's their score. And that's what a genetic risk or polygenic risk score is. So people are really interested in medicine about it. This is how they're distributed. Nice population curve here. They're really cheap to do compared with much cheaper than many other things that are done in medicine. And you can have just one genotyping, a GWAS, and you can get in the same population multiple traits and disorders. And so there's huge interest in medicine in clinical utility, particularly for future. Can we use these for prediction, precision medicine, and dissecting out some of the, making it a bit easier for us with our conceptualization of diagnosis? Well, in some areas of clinical cardiovascular medicine, people use risk prediction already for cardiovascular disease, but we're not at that. We don't do that yet in psychiatry, but we may do it in very high-risk populations if we're interested in the transition to a serious illness. And of course, everyone we see in CAMS, in child and adolescent, is a high-risk group. So that's one possible future. As I've already told you, they're no good for clinical diagnosis because the genetic risks are non-specific. But we use a lot of data already in our clinical decision-making, like how soon are we going to follow up our patient? When's the next appointment going to be? And we use a lot of clinical and social variables, so it's possible that we add this to our other variables in the future, estimating disease course and prognosis, treatment, and side effects. So what is the future? Well, there's lots of problems. The target sample must be similar to the discovery sample. And a big problem is all the genome-wide association gene discovery studies have been done nearly all on people of European ancestry. And they work particularly badly, the polygenic scores, in people of other ancestries, particularly of African ancestry. That is now, there's a lot of African genetic studies on their way, but really they don't work very well. They're all only common gene variants, not rare variants, really weakly predictive, and they're non-specific. So there are a lot of disadvantages. But let me give you a potential taste of the future. This is work on coronary artery disease, where, of course, people already do risk prediction tools in clinical practice routinely in primary care and general medicine, using, in the States, it was originally Framingham. In the UK, we use Q-risk. And you can see on the left the standard risk factors for cardiovascular disease, and the risk of having a heart attack, for example. And here, those are the standard risks. And I keep pressing this. And on the, here, you can see the polygenic risk score for cardiovascular disease is quite good and actually seems to add to the conventional. So actually, there are a few studies in some countries evaluating now in practice whether polygenic risk scores add anything. I just want to say, to be cautious. The reason why I'm highlighting caution, this is not a North American audience, but I know my North American friends and colleagues are saying because you can get polygenic scores, you go to 23andMe, you can come with just a whole load of genetic risk scores. Schizophrenia is one of the top ones people ask for. They may come in clinic with these scores. It's too soon. But even in general medicine, where they will come sooner, they're not going to be used on their own. They'll be used with clinical evaluation. And of course, it's really nice that the just genetics research is being done, but when we're taking it forward into clinical, before it gets implemented, we need clinical evaluation trials. Just as anything else we introduce, potential risks as well as benefit and genetic literacy of clinicians and people we're seeing. Rare variants, testing for those is already in place. Intellectual disability, developmental delay across most high-income countries, and in certain parts of the UK now, sequencing of newborn is starting to come in. Schizophrenia, just want to highlight in case anyone didn't know, but the prevalence of high-risk copy number variants is 5%. And actually, the Royal College of Psychiatrists in the UK is releasing guidelines this year. I was on the working group that we should test for these in schizophrenia. Of course, we see the early onset, so we should be looking at this. AS for the neurodevelopmental disorders, most guidelines do not suggest this unless there's something else, dysmorphic features, a comorbid physical condition. Check your national and local guidelines because they do differ across countries. So just to end with clinical implications, so my favorite bit, we're going to go to clinic. What does it mean for us, all this research? I think the most important thing is please don't believe that our diagnoses, I've said they're useful, they are not concrete biologically defined entities. I don't think anyone believes that, but if you're training people. But we're not ready to dispense with them, because I know when I've said this sometimes to government policy saying, oh, should we get rid of diagnoses? No, we're not ready to dispense with them as long as we appreciate they are concepts we use rather than fundamental biological truths. And we use them for certain purposes, which they may not be useful, for example, for seeing what the educational needs of a child are, for example. I don't think they are. Be careful about rigidity. So many times, and I remember, when I was a new trainee and I got trained up in a research diagnostic assessment and a belief that your assessment, which is so careful and detailed, is going to identify who meets a true, correct and accurate diagnosis. Of course, a really detailed assessment is important, but just for us to also accept the humility that is not, no, even if you do the state-of-the-art assessment, it's going to be quite difficult in terms of getting it right for the future, and it's not a biological entity. Given that huge clinical and genetic overlaps, we have to think about hidden comorbidities, remembering to screen and telling our colleagues, if you've got a mood disorders clinic and you've got treatment resistant, have you got someone with ADHD? When we were doing an ADHD study of CAMS, we don't have much bipolar disorder in the UK. It's rare, but we did pick up in 800, we picked up about 8 cases bipolar disorder that weren't picked up. So we just need to remember that, especially with specialization. And finally, I want to end with, as researchers and scientists, we need to stay open to novel concepts. We are using our current diagnostic concepts, but we need to stay open that as future research emerges and as we test clinical utility, there may be new things to embrace as we go forward. Thank you.